Welcome everyone to the Canadian Diabetes Association's 2016 webinar series. My name is Farah Ismail and I will be your host for today. We are delighted that you're able to join us today for our webinar to learn about debunking diabetes myths. Now to start off, I'd like to draw your attention to our survey. It's located at the top right-hand section of your screen. In order for the CDA to better serve your needs, we kindly ask that you provide your input by completing the short survey towards the end of the presentation, and we thank you in advance for your input. Throughout our presentation today, you will have the opportunity to ask questions, and this can be done simply by typing in the question and answer box, and that's located at the bottom right-hand section of your screen. And our speaker today will be happy to answer them at the end of our presentation. As well, we will be displaying a few polling questions throughout the presentation and would love for your participation. It is important to note that all responses will remain completely anonymous. Also note that you're able to customize your screens. You can expand and collapse them as you see fit, so feel free to do so by adjusting the bottom right-hand corner of each of the webinar pods. Our presentation today will last about 30 to 40 minutes in length, and we'll have about 10 to 15 minutes at the end for questions. We are recording today's presentation, and we will have it on the Canadian Diabetes Association's website in the coming weeks. Now, before I introduce our speaker today, I'd like to send out a thank you to our supporter, Canola Eat Well, for being part of our program. Now I'd like to welcome our speaker, Gail MacNeill, and thank her for joining us today. But before turning it over to Gail, I'd like to give you a brief introduction. Gail MacNeill is a clinical nurse specialist and the manager of the Leadership Sinai Center for Diabetes at Mount Sinai Hospital in Toronto. She has more than 25 years' experience in diabetes self-management education, working in hospital, clinic, and community settings. Gail is a passionate advocate for the highest quality of education for all people with diabetes and all healthcare professionals involved in diabetes care. She was honored with the Diabetes Education of the Year Award by the Canadian Diabetes Association. For more information on Gail, please read the speaker bio section, and that's located to the left-hand section of your screen. So without further ado, I present to you Gail MacNeill.
Thank you, Farah, and welcome to all those who have joined us today. We're going to be looking at the myths of diabetes. Now, I know none of you have any myths, right? It's all, we know the facts. Well, let's take a look at some of those things that we think are myths. Because why we want to look at the myths is because living with misconceptions can really lead to sometimes poor and incorrect decisions as to how we manage our diabetes. So today I wanted to put some of the records straight. So we're going to actually take a polling question here and ask, how are you affected by diabetes? So do you have type 1, type 2, you're at risk, a child or healthcare professional, or you're simply interested in diabetes-related information? If you wouldn't mind telling us who the audience is today, that would really help. Okay. Oh, wow. Healthcare professionals, okay, and people with type 2. But there are some people with type 1 as well, and you have a child living with diabetes. Okay, this whole discussion today is in a general tone, and I will refer specifically at times to people with type 1 diabetes and type 2 diabetes, or type 2 diabetes, when there's differences in the thoughts that are involved. But please, if at the end of the conversation you feel that it hasn't been directed properly, let me know that, okay? Okay, so our second poll question, how are you participating today as an individual and a group of 2 to 5 and a group of 6 or more? And the answer is as an individual, okay. So we can be talking to ourselves, I guess, as we're an individual, but that's great. You've got some groups there as well. Well, thank you. And so let's get started. So as I say, the objectives today basically are just to share what I consider to be truths about diabetes. Maybe some of the issues are more controversial, and you might not agree with them, but that's fine. I will try to give an explanation of why my thought process is going in a certain direction. Okay. So let's start with one of the first myths. John has been told that he has a touch of diabetes, and he says, this is not serious. This comes back home very personally because it's exactly what happened when my husband was diagnosed. And he said, oh, it doesn't really matter. It's just a little touch of diabetes. So when you hear that, what does the word touch mean? So is this a myth or is this a fact? I'm going to suggest to you it's a myth. When you hear the word touch, it means a little or not or insignificant. And again, I know you've heard this many a time, but when having a touch of diabetes is like being a little bit pregnant. You either have prediabetes, diabetes, or you don't, okay? And oftentimes when people's doctor might say you have a touch of diabetes, what usually they're referring to is what we call prediabetes. Does this statistic stun you? 1 in 5 Canadians have prediabetes. And on the Canadian Diabetes Association website, you'll see this statement, 1 in 3 Canadians have prediabetes or diabetes. So it is a significant, it's important, and it's certainly relevant to actual diabetes. Now, this is how they're actually diagnosing prediabetes. It's in a situation, prediabetes is defined as a state which places individuals at high risk of developing diabetes and its complications. And these are the diagnostic criteria. So what I'm trying to establish here is it's not just a whim saying, oh, your sugars are a little high. There's certain parameters all the medical profession will look at to diagnose prediabetes. And that is a fasting, the first in the morning, blood sugar without eating anything. The result between 6.1 and 6.9, or a 2-hour, 7.8 to 11, or the most common way a lot of the physicians are doing things now because it doesn't require you waiting around or fasting is taking the blood test of the A1C. And prediabetes is diagnosed when that A1C test comes back at a 6.1 to a 6.4. Now, why is it important to know about the rising blood sugars? Because we can do something when we know the numbers. Take a look at this. What is this telling us right now? This is the A1C level and future risk of diabetes. It suggests that if your A1C is in the 5.0 to 5.5 range, over a 5-year period, you have a 5 to 9% of actually developing diabetes. Skip down to 6.0 to 6.5. Remember, that's the prediabetes range. You have a 25 to 50% chance of actually developing diabetes in the next 5 years. Now I'm going to ask you again, is this important? And it's very important, okay? We know that if we don't take some steps in prediabetes, that it goes on very quickly to the development of diabetes itself. Now, if you or relatives have any questions as to what the risk factors are in prediabetes, on the Canadian Diabetes website, there is a CAN risk questionnaire, an excellent questionnaire that gives you an idea whether you're at risk or not at risk. And basically, any level of high blood sugars increases, remember, the risk of heart disease. So, important to prevent complications is to treat early and aggressively. So, if you have relatives that have got questions, am I at risk? This is a great questionnaire available on the website. So in response to the diagnosis of prediabetes, it's important and we need to work with it. And prediabetes is a reality. It's not a touch of anything, okay? It is prediabetes, and the seriousness is it can go on to develop diabetes very quickly if we don't do something about it. So here's another myth or fact. So here's Manuel, and how many times Manuel was told he's recently developed type 2 diabetes, and he was told he developed type 2 diabetes because he ate too much sugar as a child. His question is, though, my sister ate a lot more sweets than I did, so how come she doesn't have diabetes? So is eating too many sweets the cause of diabetes? Is that a myth or is that a fact? And I'm going to suggest to you it's a myth. And unfortunately, when people say, oh, it's something that you've done, it implies a sense of guilt, like I brought it on myself. But as one of our famous educators said, Diabetes is not a character flaw. It's a disease, and it's caused by multiple factors. And actually, in regard directly to eating sweets, it's actually when you eat more fats and put on weight that contributes to insulin resistance that is more contributing to the development of type 2 than eating sweets. And what causes? The question is, what causes diabetes? And that's basically what this question was asking. So this is Dr. Joslin, and I love reading about Dr. Joslin. He was one of the first doctors in the world, actually, to specialize in diabetes. And he founded the Joslin Clinic in Boston, actually, and it's still operational today. Now, we're talking about founding this clinic back in the 1910, 1912, 1914, where they really didn't even know what diabetes was or what's causing it, long before actually the discovery of insulin. And he spent his entire life working with patients with diabetes. And his comment is, genetic loads the gun and the environment pulls the trigger. So what does he really mean by that? Well, if you take a look at type 1 diabetes, you're born, we have the genetic predisposition to develop diabetes, but it's an interaction with a virus or some sort of trigger in the environment that causes our immune system to overreact. It can fight the virus, for instance, but it turns around and fights our own system that makes insulin, and it affects the beta cell. So that's in type 1 diabetes. In type 2 diabetes, we have a predisposition to the development of diabetes, but think about it, back a while ago, the heaviest man in the world didn't have diabetes, okay? So he didn't have the genetic makeup. But if you have the genetic issue with the development, there's many different genes that they've looked at contributing to type 2 diabetes. And then on top of that, we're going to put on weight and we're less active. All of these build into insulin resistance. So it takes, the cause of diabetes is genetics are there, and then the environment is involved as well. So, but I always say it's not our fault if we have developed diabetes, but it is our fault if we don't do something about it. That's the important factor, okay? These are the risk factors. We should know the risk factors and work with what we can, unfortunately. These are the risk factors. So knowledge is a very, very important. And remember that the development of diabetes is multifactorial. There's many different issues. Okay. How about this one? This is the opposite side of the coin where the person says, I don't know why I got diabetes, and the other person says, well, I know I'm going to get it. So many of my relatives have diabetes, it is in my destiny. I know I will get diabetes. Is that a myth or a fact? And I'm going to suggest it's a myth because, you know, you have families that have 6 children and 2 develop diabetes and the other 4 don't. So how do we tell for sure, for positive? We really, really can't. But we do know that there are modifiable factors and unmodified. Now, we can't change our age yet. Fountain of youth has not been found. Gender is modifiable. Really, in our sense, it's not modifiable, okay? Ethnicity and then a history of gestational diabetes are factors that we really can't work with. On the other side of the coin are the factors that we can work with, okay? And these are the abdominal obesity. We can work with physical inactivity. And the metabolic syndrome is something where you see increased waist circumference, you see increased blood fats, particularly the triglycerides, you see increased blood pressure, and you see an increase in the fasting plasma glucose. Those are all contributing to the metabolic syndrome, which you see a strong relationship to those issues and cardiac conditions too, don't you? So we can do some work with that. Those are definitely what we call modifiable risk factors. And one of the programs very clearly told us, one of the largest studies that was done, told us very clearly that we can actually prevent the progression from prediabetes to diabetes. And what they did is they divided the 3,000 people into 2 different groups. One was a control group where they didn't do anything different. The other one, they actually had medication, and another part of the group, they had intensive lifestyle modification. If you take a look at this, called the Diabetes Prevention Program, which group had the highest prevention rate from going on to develop diabetes? And if you look at it, you'll see it's the lifestyle. So we can prevent the progression of diabetes. I don't know for how long. I'm not going to say forever, but they suggested by 58%, okay? And the lifestyle interventions they used were activity and looking at the food, and they were aiming for a 7% weight loss, because even a small amount of weight loss will actually help lower those blood sugars. So in other words, there are things that we can do to prevent diabetes in type 2. Type 1, we don't have the information, and at this point in time, we don't really know how to prevent type 1 diabetes. What we do know, either way, type 1 or type 2 with the numbers, we always should be understanding the factors that affect our blood sugar and working with the food, the activities, medications, and the emotions. I call it the FAME method. Once we've got it down pat, we're famous, is what we usually say. Okay, so we can prevent diabetes. We need to know about prediabetes, and we can do some work to prevent it. So let's take a look at another types of diabetes now. So as a myth or fact, Paula was confused when she was diagnosed with type 1 diabetes at 35 years of age. She always thought adults get type 2 diabetes and children get type 1. So is it true at 35 years of age, can you develop type 1? Well, truth is we can develop type 1 at 35 years of age. So it's not always true that children have type 1 and adults have type 2, okay? The Canadian Diabetes Association differentiates the different kinds of diabetes for us. So type 1, they're saying, is due to pancreatic beta cell destruction. What that really means is that the pancreas doesn't have the insulin to put out to the system. So in other words, in type 1 individuals, there's been a destruction of the actual cells that make insulin, so there's no insulin. Generally speaking, no insulin being made. In type 2, it's a slow deterioration of the beta cell and either insulin resistance or not enough insulin, and you develop, as they say, relative insulin deficiency. There's just not enough insulin to get the job done. So this really differentiates how we treat, because in type 1, we have to use insulin. We have to replace the insulin that's not there. In type 2, we can work with the cells that are making insulin, coaxing them to make more insulin, or helping the body use the insulin that we're being made. So that's why we use medications and pills in type 2 more so than in type 1. And the other type of diabetes, of course, is the gestational diabetes, which occurs when you're pregnant. And there's other kinds of diabetes. Medications like steroids can contribute to diabetes, and some people are born like leprechaunism. These people develop diabetes too, and that's what's called the other type. By far, the majority of the people with diabetes, 90 to 95% of the people with diabetes, have type 2 diabetes. But I wanted to draw your attention to type 2 diabetes in youth. We are finding that we used to think that type 1, and we still do, generally see type 1 under the age of 30 and type 2 over the age of 30. Those are generalities. I just had a 50-year-old diagnosed with type 1 the other day, though. So, again, we have to be open to this. But one of the biggest problems we're seeing right now is this type 2 diabetes in youth. And what is happening is the diagnosis of diabetes, type 2 diabetes in youth, is following the obesity patterns of children. And right now, 26% of the Canadian youth in the age 2 to 17 are overweight. And this is going to be astounding, but childhood obesity has tripled since 1975. Now, we don't have to use much of an imagination to know why that's happening with all the computer work and et cetera, but it is becoming a major public health concern. So my biggest advice to everybody out there with their kids, if you have type 2 diabetes, get your kids moving, okay, because they've got probably a genetic issue with, that the potential to develop type 2 diabetes. Get them moving, healthy eating, and limit the sedentary time. And if a child does develop type 2 diabetes, we definitely treat them in the pediatric teams, and we use family interventions is what we're looking at. But I just wanted to draw that to your attention because I think it is a big concern that we don't always think about. Okay, myth or fact? Sarah has diabetes, and her neighbor told her she must eat the diabetic diet. Now we're getting into all these myths about food, and there's a million of them, okay? We could do a whole 3 hours just on food alone. So I'm just going to touch some of the areas. Is there such a thing as a diabetic diet? Well, I'm going to suggest that there isn't. Because really, the effective meal plan for anyone with diabetes is one really that enables you to keep your blood sugar, your cholesterol, your blood pressure, and your weight within your target range. Also, though, allowing you to enjoy what you eat and not feel overly restricted. So the actual diet recommended, all these things about no sugar, sugar-free foods, and healthy foods don't raise, we've heard all of these, and I've got to suggest to you that these are myths, okay? What they're recommending, any unhealthy diet for the general population is going to be unhealthy for the person with diabetes as well, and vice versa. Anything healthy for the general population, in the most sense, is appropriate for a person with diabetes. A couple little scenarios, for instance, would be fruit juices. Fruit juices are loaded with sugar. Probably better off a person with diabetes to actually eat the fruit. But in a general sense, whatever is healthy for one person is healthy for the next. And there are just a million tools out there to help us deal with this. We've got, the plate method up in the top left there, where half your plate should be vegetables, a quarter carbohydrates, and a quarter the other. We've also got considerations like the glycemic index. We've also got fantastic tools to help us read labels. All of this can be facilitated by a visit to a dietitian, okay? Or there's lots of information on the Canadian Diabetes Association website about this as well. Lots of tools to work with. But the food is always, always going to be a major part of how we deal. In type 1, we're matching the carbohydrates and the insulin. And in type 2, it's usually some weight loss issues that we're looking at. And so the food is always going to be a major concern. But just try to keep, there's some very simple factors about the grains, stay away from the juices. And as I say, using the plate method and quantities are always probably the easiest ones to go with. But I think you've had a nutrition one, so I'm not going to dwell on that one. But there's no such thing really as a diabetic diet. Now, I thought this was just really interesting. I wanted to draw to your attention because how many times have you heard a person say, oh, I'm on such and such a diet and it's doing such and such? So is there some magic diet that we can really go on to control our blood sugars? And I have to think when you're looking at this, those are many different diets on the market. And these are healthcare professionals have looked at them in relationship to diabetes. And really, a lot of them decrease the A1C, but again, some of them, be careful with ones like the Atkins diet there, where it actually increases the LDL and decreases the micronutrients. And the other one is be careful like something like the protein power plan. A lot of people are using protein powders and power tubes for all this kind of stuff, but be careful because take a look over the disadvantage. It increases the renal load. And of course, kidney disease is one of the silent killers of people with diabetes. So be careful. Again, if you're going on a diet, you have diabetes, please check with a dietitian. They can give you much better advice. Okay, here's a myth or fact. Hans believes I'm not supposed to drink alcohol because it raises my blood sugars. But of course, he can't do without his beer. I mean, how many people can do without their beer? But okay, myth or fact. Does alcohol raise the blood sugars or not? And with this one, I put myth, but I also put the word fact. Now, let me clarify what I really mean by this, and we'll take a look at what the Canadian Diabetes Association recommends and why I say it can be a myth and a fact, but it also can be a fact. Because alcohol in itself won't raise your blood sugars, and this is on the Canadian Diabetes Association website. It won't raise your blood sugars, but there's often sugar added to the drinks, such as coolers and liqueurs and different sodas. Those will add, like if you mix a drink, let's say you have vodka and vodka and Coke, well, the Coke is going to put the sugar into the system. The vodka itself doesn't actually have sugar in it. It's the way it's converted in the body that those actual liquor like that does not convert into sugar, but it's what you mix with it. And if you have a sweet liqueur or sweet wines, they will definitely affect. But the interesting thing is if you're taking insulin or certain oral medications, you can actually go low with the blood sugars can go low because the alcohol can affect the liver. And the liver, in the middle of the night will be putting out sugar to help maintain your levels. But when you take alcohol, what happens is the liver gets busy detoxifying the alcohol and doesn't put sugar into the system. So we always tell people if they are drinking that they should be having something to eat as well. Another thing that's been changed in the last couple of years, we used to consider that when you had a regular beer, we would consider it eating like a piece of bread. Well, now at this point, we don't consider the carbohydrates in the actual beer because we find that the alcohol neutralizes this and balances out the carbohydrates because of the effect the liver has on the liver to lower the blood sugars. But another thing, be careful. When it talks about light beers and things, be careful they're talking about low carbohydrate beers or how is it low alcohol. You can get different things from the different labels. The important thing about alcohol itself is it has calories. So if you have type 2 diabetes and you're trying to lose weight, sorry guys to tell you, but you're going to put on a lot of calories, and they call them waste, maybe not so waste as some, but they call them waste calories. So that's the issue. There's a lot of calories, and you put on a lot of weight with alcohol consumption. Now, they're always suggesting what is a typical moderate alcohol take and what is suggested. And they're suggesting moderate alcohol intake is limited to 2 standard drinks a day, or less than 10 drinks in a week for women, and less than 3 standard drinks, less than 15 drinks for men in a week. And these tell you what a standard drink is. Beer is 12 ounces of beer, and spirits, generally speaking, would be 1.5 ounces, and the wine would be like a 5-ounce glass. That's what they're considering a standard drink. So no more than 15 in a week for men, and again, that's not fair for women, right? No more than 10 a week for that's not fair, but okay. Okay, here's another one. Myth or fact? Standard believes if I lose weight and don't need my medication to control the blood sugars, my diabetes has gone away. In other words, if I lose weight and I have to get less medications, does that mean I don't have diabetes anymore? Is that a myth or a fact? And I'm going to suggest to you it's a myth. We can definitely, with weight loss and type 2 diabetes, we can definitely decrease our medications, and maybe to a point where we aren't even taking any medication in type 2 diabetes. But the fact that you had diabetes at one point in time, it means that your genetic predisposition is there and that you actually have diabetes. And in type 1 diabetes, it doesn't matter how much weight you lose, you will always need insulin because your body is not making the insulin. So it doesn't change the fact that we have diabetes. What it does is change the fact of how we actually manage the diabetes. So as we saw in the diabetes prevention trial, that weight loss definitely helps to control the blood sugars. Even they were going for 7% weight loss in the actual diabetes prevention program, but they're saying even a 5 to 10% weight loss will significantly help improve the blood glucose levels. But you're always considered to still have diabetes, even if the sugars are in great control. How many times have you heard someone say, oh, my sugars are in control, so I'm not going to take my insulin? Well, a lot of times it's the insulin that's controlling the blood sugars, and so you need to always check with a physician before you change your medications. And also, you'll find that under stress, usually the blood sugars go up, and then when you get sick, the body, in its way of helping you cope, it will put sugar into your system. So even though your blood sugars are in great control, you might in type 2, you went off the medication, lost the weight, you'll find in these times of stress and sick days, your blood sugars will often go up. So we consider, even though weight loss, etc., you still have diabetes. It's the way we manage it that has changed. The only diabetes that people have said goes away is actually gestational diabetes. And this is diabetes that's been diagnosed when you're pregnant. Usually around 24 to 28 weeks, women are screened for this. And basically what's happening is as the baby's growing, it's creating more insulin resistance in the mother's body, and her body is having trouble actually putting out the insulin necessary. When the baby is born, the hormones go out with the bathwater sort of thing, so the hormonal level returns to normal. So they say gestational diabetes goes away. However, let me just draw your attention to the fact that once you've had gestational diabetes, many of these women go on to develop diabetes later in life, and the child has a higher predisposition to development of diabetes. So my question to you is, does it really go away? Okay, another myth. Helen believes if I have to take insulin, it means I'm a failure. And this is the beginning of the end, is how she feels. And, you know, in practice here, a lot of people say, well, is there nothing else I can do but use insulin? And I'm going to suggest to you that insulin is the most natural of our medications because it's what the natural body is producing. The fact that we have, in the past, used it too late, I'm sure you've heard people comment, oh, my aunt took insulin and she went blind, or these kinds of myths that are there. The problem is we've started to use insulin too late in the process. That's the problem. Because take a look at this slide here. I know it's a little confusing, but it says natural history of type 2 diabetes. And what you'll find is that the beta cell, over time, almost regardless of exactly what we do, the beta cell will deteriorate with age. They suggest that at the time of diagnosis of diabetes, probably only about 50% of those cells that make insulin, the beta cell, are actually working. And over time, that you can use about 5% of the beta cell per year. So you'll notice over the left-hand side, 10 years before we even diagnose diabetes, you've got the postprandial, the blood sugars after a meal are rising, the fasting blood sugars are rising, and the ability of the insulin secretion tries to match that. But at the point where the blood sugar is just rising too high, the pancreas cell, the beta cell, starts to deteriorate, the insulin secretion starts to fall down because the beta cell can't keep going, the one that makes the insulin. At that point in time, you'll see the rise, even higher, steeper rise, of the actual postprandial and fasting blood sugars. Now, that's the time we diagnose. And it's too late, right? You can see all of these things are happening earlier. As our insulin resistance and the beta cells starting to decline, our body tries to make up and keeps pushing and pushing for the pancreas to work. And eventually, the pancreas reaches a stage and says, I can't do this anymore. It starts to drop off, and that's when we've diagnosed diabetes. Too bad we don't have tests that can measure this way, way over earlier. So, in the body. So the point of this one is that insulin is a natural product, and maybe, here's a thought for you, maybe we should be using insulin a lot earlier. And some of the studies going on right now, one of our physicians here is doing a study using insulin as soon as the person is diagnosed. Because what they feel is if we can put insulin into the system and give the actual body a rest, maybe we can delay the cell from deteriorating. So it's an interesting thought, and they've got quite a bit of success with it. And actually, at the Joslin clinic, you were using that years and years ago. So the idea is we may be seeing insulin using a lot earlier because, again, it's a natural product that the body needs. Now, here's a good one. So we got Homer here, okay? Recognize Homer? Okay. Homer believes if I start insulin, I can eat anything I want. I've started insulin, so I can use it and control the blood sugars with the insulin. Well, it's a myth. We can definitely control the blood sugars with the insulin, but you shouldn't be eating anything you want. Because just like anybody in the general population, okay, if you eat a lot of food that the body doesn't need, what happens? Gain weight. Now, in diabetes, sure, we can put in as much insulin as we need to actually take all the carbohydrates you're eating, but should you be eating that many carbohydrates? And this is where you have to really look at this and say a healthy diet is necessary, whether it's insulin or not insulin. Now, when some people start insulin, particularly in type 1 diabetes, when they start insulin, when they're diagnosed and start insulin, they'll often gain weight. And the reason that is because when they were not diagnosed, they were losing a lot of their calories through the urine because there was no insulin in the system to grab that sugar and put it in the cells. Once they're diagnosed and we know they need insulin, then the insulin will grab the sugar that they've got and put it in the cells and use it as energy. So they will often gain back the weight they may have lost. In type 2 diabetes, when we need to use insulin or when insulin is appropriate use, we will put it in. We'll look at the food you're eating, the activity you're doing, and put the insulin in, okay, to match what you're eating. you should never actually put what should be happening is that when you put the insulin into the system, it should be in relationship to what your nutritional needs are. Yes, we can put as much food in you want and match it with the insulin, but that is going to end up with a weight gain. So the idea is that we put insulin in to match the carbohydrate intake. We do not match the food to the insulin, but rather the insulin to the food you're using. And this is a completely misleading cartoon here because, number one, they've got them sipping insulin out of a bottle. Well, the only way right now to give insulin is via the pump or via injections, okay, because it goes under the subcutaneous tissue. And this gentleman obviously is not learning to manage his diabetes with insulin, because if he keeps eating like that, he's going to put all those carbohydrates in or all the calories in, and in order to get his sugars under control, we'll match it with the insulin. But if he doesn't really need all those calories, what happens? He keeps gaining weight. So the idea is that we match, okay, we match the food and the insulin together. We don't ever eat up to the insulin. And you should always be having a healthy diet, insulin or no insulin. Okay, how about the next one here? Sean heard that diabetes is a leading cause of blindness in adults. Think that's a myth or a fact? I'm going to tell you it's a myth. I know you might be surprised, but let me explain why I say it's a myth, okay? Just for interest's sake, this is what diabetic retinopathy looks like. On the left side, you see the normal vision. On the right, this is a person with diabetic retinopathy. And diabetic retinopathy, it's caused by the damage to blood vessels of the light-sensitive tissue at the back of the eye, or known as the retina. And initially, diabetic retinopathy may have no symptoms at all, and this is why you must be going to the eye doctor to have it checked out. However, it can progress to see the blurred out part of the vision on the right. What happens with diabetic retinopathy is the little blood vessels you'll see that are in the retina there, they're very susceptible to high blood sugars. And when the sugar is high for a long period of time, these vessels back in the retina start to leak and they form hemorrhages. When the light is coming in and hits that hemorrhage, it's going to reflect the light very differently, and it actually you can't see properly. Now, why I said that diabetic retinopathy is the leading cause of blindness in North America, it's not actually, it's uncontrolled diabetes. So if your blood sugar is in great control, the retinopathy is one of the first complications that you can actually prevent. So it's uncontrolled diabetes, and you'll find that a lot with the complications we're talking about. The famous studies they've done, the Diabetes Control and Complications Trial, the United Kingdom study, told us if we control the blood sugars, we actually can definitely delay, if not prevent, the complications. And some of these studies have been going on now for 23 years, and what they found is that if earlier you have better control, then the better it off even 20 years later. So it's called the legacy effect, and the other is called the metabolic memory, both in the United Kingdom study and the diabetes in type 1 and type 2. The earlier you have good control, the better off you'll be as far as the complications. So this just goes to show you the microvascular complications, or the small blood vessel complications associated with diabetes. And as the A1C, that blood test you have done once every 3 months, or if you're in great control, one every 6 months at the doctor's, as that starts to climb, you'll see the more and more complications. So the idea is the A1C should be kept in good control, and the average person should have an A1C roughly around the 7%. Here's another one. Oh, Hera believes that if she controls her blood sugar, she will not have a heart attack. Well, I wish that were true, but it's relatively myth, because as we talked about the small blood vessels of diabetes and the complications, we know by good blood sugar control we can prevent the retinopathy of the eyes, we can prevent kidney issues, and we can prevent the nerve and foot complications. We know if we control the blood vessel, the actual diabetes, we can do that. However, how blood sugar control actually relates to the heart and all the macrovascular is a bit of a different issue, and that's sort of a confusing issue, and there's so many more parameters involved in heart disease, so there's so many other things we need to be looking at. So again, I just want to draw your attention, a bit of a confusing slide, but I wanted to draw your attention to the lower left-hand side. In the term prediabetes there, you'll see they're already saying there's a cardiometabolic syndrome. Something is happening early on. So this draws to mind, does diabetes contribute to heart disease, or heart disease contribute to diabetes? And if we only knew the true answer of that one, we'd be working to find the solution. We do know, though, that anything we do to help with the small blood vessel disease and diabetes that prevents those complications will help to prevent some aspects of the actual heart disease as well. And this has been fantastic news in our diabetes world that came out last September, and it's called the EMPA-REG. What does this all mean? It means that there's an actual drug, and now there's 2 drugs, that actually if we're taking these drugs for diabetes, they will help prevent some heart problems, okay? So this study was done in people with diabetes and with some severe heart problems. What they found by taking the certain medications, there was a 38% relative risk reduction from death due to cardiovascular causes, less hospitalizations, and actually less death. So also we now have another drug. So this was one of the SGLT2 inhibitor drugs that they're using. Another study came out called the LEADER study that showed us another drug we've been using, liraglutide, also has similar benefits for the heart. So this is a totally exciting news, because before, any medications we used for the diabetes and the blood sugars did not necessarily relate to any cardiac protection. So now we're saying we've got some drugs in diabetes that we can use to help with heart problems as well. So, however, the bottom line is this is what we call the vascular protection checklist. We should always, in order to prevent heart problems or work with this, we have to look at the blood sugar, blood pressure is an added one, cholesterol, and we have the ACE inhibitors, exercise, and smoking cessation. So as I said, cardiac disease is a much more complicated and multifactorial aspect than the complications of diabetes. But whatever we're doing to help with the small blood vessels and prevent with the blood sugars will also help prevent work with some of the preventions for heart problems. Okay, how about this one? Only people with bad diabetes need to use those meters to measure their blood sugars. And Ian says here, I don't need to know what my blood sugars are. Well, if he doesn't need to know them, who does, okay? Because diabetes is a self-managed disease, okay? The doctor doesn't control this. You should be working with this. And the easiest way to know what your blood sugars is to somehow be monitoring them. Now, we have meters that we can use at home, and you go and you have your A1C done, but what's the relationship between the two? Because sometimes the A1C will come back, and let's say the A1C was at 8%, but when you were using your meter at home, it only said the average reading was 7. Okay, that probably means that we're not using the meter at the times capturing when the high blood sugars are. So if somebody comes in and their A1C is high, and yet the meter readings they've got in front of them are fine, we'll have them metering at different times to find out when those blood sugars are high. So there's a relationship between meter readings and the A1C. Both are very, very helpful. There's many different ways. The A1C, I have to draw your attention to this part, because the A1C, it doesn't tell the whole story because it doesn't reflect the day-to-day variances. So the person here, both people have the same A1C. The person on the left here that follows within a narrow range probably feels really well. The person on the right, look at the ups and downs and ups and downs. I just had a patient in my office saying that blood sugars going from 2 to 20 is wrecking things. It's a horrible quality of life with those blood sugars. So we need some more information, and meters actually on a day-to-day basis can give you that kind of information you need. Now, there's many ways when you're using the meters, or if you're using continuous glucose monitoring as on the right-hand side. Either way, monitoring and metering your blood sugars is essential on a regular basis to give you the information you need to know in order to control your diabetes. So either way, however you do it, you need to know your numbers. You need to know what you're seeing. Okay, here's another one. Susan, if my blood sugars are in control, there is no need to see my doctor. And this is the same idea. If I feel fine, then everything's fine. And that is not necessarily true, especially when we have diabetes, because there's a lot of silent problems that you may not recognize or not have symptoms for in diabetes. So that is definitely a myth, and I strongly encourage you to keep track and keep in contact with your medical team. There's many things we look at when people come to visit us. So we look at the A1C, which is a blood test. We always are looking at the blood pressure. We're looking at cholesterol, okay, all those things. But the other aspect we're looking at dramatically too is the kidney, because the kidney issues are silent. Do you know? Can you feel when your glomerular filtration rate, for instance, the rate at which the kidney can get rid of waste, can you feel that going up and down? And the answer is no. How about we measure creatinine? And creatinine is an enzyme in the body that we feel that when it starts to rise up, it means that the kidney cannot get rid of the waste products. You would have no idea because those two measurements you don't necessarily feel. Well, you don't feel. So you need to be visiting your doctor on a regular basis to have these kinds of monitoring tests done so that we can prevent the complications. Okay. This is a controversial one. Here you go. John says there's nothing good about having diabetes. Now, what are your thoughts on that one? I hear this a lot, but I hear the opposite. I'm going to say that even though you may not appreciate it, there are some good things about having diabetes. And what do they look like? Well, emotional reaction, we know that when you're first diagnosed with diabetes, you might feel, no, wrong, this is wrong. Like that's the people in the pre-diabetes stage often. You may experience fear, apathy. These are all natural reactions. And angry. Why did this happen to me? Like Manuel at the beginning, my sister should have got diabetes because she ate the sugar. I didn't. Or some people, though, start to feel relief. And this is even a different one. Some people see it as an opportunity to change. Because really, when you are looking at the diabetes lifestyle, okay, and what we're talking about, the food and things, would not everybody be better off if they were exercising and eating a healthy diet? So is this just a wake-up call when we're diagnosed with diabetes? Now, that's not to say we don't understand that there is an awful lot that has to be done. It can keep us very busy because these are all the suggestions that we're taking. Dr. Polanski is a famous psychologist on the West Coast, and he's talked about what we call diabetes distress. And he describes that as a stress related to all the activities required to keep your blood sugars in control. And the problem is, even when we do our very, very best, okay, sometimes the results are still unpredictable. And when we do control, there's no guarantees that everything will stay the same. And it can be very, very frustrating. We definitely recognize. But Dr. Polanski suggests that what we have to do is we have to manage our expectations. That we think we need to be perfect, that those numbers always need to be in line. And we talk about the numbers as good and bad, where maybe we should be talking about them as up and down. And someone described our blood sugars one time as like a weather vane, okay? We control certain parts of it, but other parts we can't. And the issue is right now, we don't have the perfect tools to actually manage the blood sugars perfectly. So the bottom line is that we have to be realistic, and we're very well aware that managing the food, the activities, the medications, the emotions is always a balancing act, okay? But I was interested, too, I was looking at the other night, I wanted to know what diabetes had prevented people from doing. And so I was online looking. I didn't realize that I'm a football fan, right? But Jay Cutler, who is the quarterback for the Chicago Bears, has type 1 diabetes. And a bunch of other football players, Mike Eccles, Kendall Simmons, all have type 1 diabetes. Nick Jonas, our singer, obviously, Brett Michaels, and Haley Berry all have type 1. So has diabetes held them back? And the answer is no. We realize it's difficult. It's a balancing act. But there are some things. Remember, too, that there are people out there that can support us, whether it's your partner, whether it's a medical team. There are people there that are helping you to live with this. And that when the burnout comes, okay, we need support. That's definitely a fact. So I'll leave this to your imagination. What this one says is, water the flowers, not the weeds. But Sir William Osler, who is a famous English physician and philosopher, this is what he suggests. He states, to live a long and healthy life, develop a chronic disease, and take care of it. Interesting. More the positive aspects I'm looking at this one in time. And this sort of falls in line with this one, where here she says, I need my blood sugars to always be in target to prevent complications. Is that true? or false? And the answer to that one, it's a myth. One high blood sugar is not going to set your A1C off. Your A1C, for instance, is an average of your blood sugars over time. And we know that nobody is perfect. But the complications of diabetes do not come because you had one high blood sugar. They come when the sugars are always high and staying high. That's where the complications come. So there's many tools like CGMs and the meters and things, and we can keep track. We need to know what our numbers are. That's the important part. And please don't go for perfection. It's not going to ever happen. We don't have good enough tools to actually replicate what the natural body is doing. Okay? So we're not going perfection. We're just going for control is what we're doing, with the realization, setting expectations that are realistic. And how do we do this? We look at things that are affecting the blood sugars. Not only look at them and take the measurements, but we actually find the patterns and the trends, and we make some adjustments. And that's the way we can work with our diabetes. We need to know knowledge is an exceedingly powerful thing. Doesn't mean it converts to action all the time, but it's exceedingly powerful to know your blood sugar targets, okay? This is where we're aiming for. So many times patients come in and they'll show me their logbook, and I'll say, well, what would you like your target to be? And they hadn't thought of this in relationship to themselves and their lives. We need to personalize this. You are in control. So here are some questions, a little polling to see if I made any sense today, okay? How about this? Is it myth or fact you can be diagnosed with diabetes directly because of eating too many sweets? Do you think that's a myth, or do you think that's a fact? Aha! Thank you very much, okay? Thank you. Okay. How about the next one? You can only be diagnosed with type 1 diabetes as a child. And absolutely. Thank you very much. Okay. How about if I lose weight, I can get rid of my diabetes? And thank you. Great. Okay. So just in summary, myth or fact? These are facts. Diabetes is not a disease. It is a disease. It's not a character flaw. You are in charge, and good control early prevents complications. You need to know your numbers, and you can't eat carbs, okay? Keep active and seek support. Facts. And diabetes management, the success involves individualizing the care, treating to target, and treating early. So with those in mind, success is in your future, okay? Thank you, guys. That's what the myths of diabetes, and hopefully we've had an interesting thought process or provoked some thought today. So I'm going to turn it over to Farah for any questions that might be there.
Thank you so much, Gail. You've definitely debunked some of those diabetes myths for us, so we thank you so much for, for all of that great information today. I know we're coming down very close to the end of the hour today. We have just about 5 minutes left, so I'll do my best to get some questions answered, but I know there's still quite a few here that we probably will not be able to get to, so please do not hesitate to email us at webinars@diabetes.ca. Gail, our first question here is one of our participants is asking if, in fact, there is a relationship between vitamin B deficiency and type 1 diabetes.
Again, I think there's been some research on it, but a lot of the major reason in type 1 diabetes is a genetic predisposition and the actual reaction of the immune system. So whether that's contributing it to or not, I can't answer that one completely, okay? Sorry about that. But again, type 1 is primarily, it's about 70-80% is an immune response, and they can measure antibodies and things like that. So that's a major part of the development of type 1.
Great. Thanks for that, Gail. Our next participant has asked, can metformin have any cardiac protection?
There's been debates about that one, and they've looked at research on it, and some people say yes, and some people say no. If you ask the physicians, the major reason, if you want to look at through the back door a bit, is the metformin primary purpose, or primary response in the body is it decreases insulin resistance, okay? And it works on the liver to stop putting sugar out. So if you feel that decreasing the blood sugars is going to give you some cardiac protection, then yes, we can say it does, but it's not known as a cardioprotective medication. What is known is those two studies I talked about, and those two medications, the liraglutide and the empagliflozin, are the ones that have proven to date to have, with diabetes, cardioprotective elements. Okay?
Great. Thank you for that clarification, Gail. Our next participant has asked about inhalable insulin, and to your knowledge, is it safe and effective to use?
So the story on inhalable insulin is it came to market several years ago, and just the uptake was very poor, whether it was the sponsoring of it or whether it was the difficulty teaching it, carrying it. There's a lot of different ifs, ands, and buts. So then a gentleman in the States decided once it went off the market that he was going to make it come. And so there is an actual inhaled insulin on the market in the United States. And I think to date, for the people that are using it, it can be used quite effectively. It has some major problems about inhaling, and if you have a cold, there's some other reasons about that. The biggest concern years ago about the inhaled insulin was actually its effect on the lungs, but they did all these aging tests. It's very interesting how they watch all these aging tests with the lungs. I guess when they came back to market, it's safe, but it wouldn't come through the FDA. We don't have it in Canada, and I think, again, just bringing it to market, bringing it up into Health Canada has been a problem. There's actually quite a few medications and different pumps and things that we don't actually have in Canada. They have it elsewhere in the world. But the people that are using it, I think you'd find that they say, yes, it is effective for them, okay? Each people have different reasons for using the different medications. Okay.
Great, thanks for that, Gail. Our next participant has asked, to your knowledge, can plastic surgery to remove the fat around the abdomen help with controlling diabetes?
I am not able to answer that one. I just don't have the knowledge exactly to do that. I know I can just relate to the fact that it is that abdominal obesity, but it's around the organs. It's not the actual outside fat, it's the inside fat. So I can't answer that one. I don't have enough information to know about that one. Okay. I know bariatric surgery is definitely, but that's a totally different concept. It's redoing the sort of the digestive tract. So.
Great. Thanks for that clarification, Gail. Our next participant has asked, if they're experiencing a low without taking any food, is it possible for their blood sugars to go back up to normal?
So it depends if they're on a medication that causes low blood sugars. And I can relate this to experience when I worked in the community and people were taking metformin that's not supposed to cause low blood sugars, or they weren't taking any medication and they were learning to use a meter. Many people would come back with, not many, but some people would come back with blood sugars of 3.2 and 3.8, and we would call that low blood sugars. But as Dr. Yale in Montreal explained, we've set a number of 4 as being a low blood sugar, but that's really only for people that are taking medications that artificially lower their blood sugars. In other words, some people can walk around with a normal fasting blood sugar of 3.2 and 3.5, and naturally then their blood sugar would just come back up. It depends if they're taking a medication that lowers their blood sugars, like the sulfonylureas or the insulins in the world. If you're taking that, I wouldn't trust that my blood sugars are coming back up. But if you're not taking any of those medications, yes, your blood sugars will probably come back up on their own.
Great. Thanks for that, Gail. And I'll just take our last question here. It's actually come from a couple different folks, and they're wondering if type 1 diabetes in a young child is caused or perhaps could have been caused by a virus, a cold, or an illness, to your knowledge.
Exactly. That's exactly what they're suggesting. Now, but keep in mind that it's a combination, as we saw what Dr. Joslin has said, it's a combination of the environment and genetics. Because in a family, the same children could have been exposed to the virus, and one develops diabetes and the other one doesn't. So that's the way the genetics interacts with the environmental factors. But what we think is happening to quite a few people, as I said at the very beginning of this about type 1 diabetes, is that the body actually is fighting off some sort of virus, but the immune system turns on itself and destroys the beta cells that make insulin. What is a trigger factor? We're not entirely sure. How we can prevent that from happening, we don't have that information yet. But very, very clearly, yes, in a response to virus and things, you'll see often the child will have the flu, and then it seems to get over the flu a couple of days later they get very ill. But remember, it's a combination of factors. There's genetic issues, and then the environmental influences on that. 2 to tango.
Great. Thank you for that, Gail. And folks, that does conclude our webinar for today. If we didn't get your questions answered, please email us at webinars@diabetes.ca, and we'll be happy to follow up with you. I'd sincerely like to thank Gail for speaking on behalf of the Canadian Diabetes Association, as it's been a very great learning experience. We do also want to thank our supporter, Canola Eat Well, for supporting our webinars program. And I do want to also remind everyone that our webinars has been recorded today and will be made available on our CDA website in the coming weeks. We do have 3 more webinars left for the end that'll take us through to the end of the year. So please join us next week for learning about stress and diabetes. That'll be followed up with some really great holiday survival tips to stay on track with your diabetes during the holiday season. And we will be touching on the glycemic index to end off our series on December the 15th. This Saturday, actually, November the 26th, the Canadian Diabetes Association will be hosting our South Asian Expo. So for those of you in Ontario, this is an event you definitely don't want to miss. For more information and to register, please visit www.diabetes.ca/expo. As well, in the spirit of Diabetes Awareness Month, the Canadian Diabetes Association urges you to reach out to your family and friends and colleagues to take the CAN risk test and to know your risk for developing diabetes. So for more information and to access this test online, please visit www.diabetestest.ca. And for those of you looking for more support and resources for living well with diabetes, please feel free to call our toll-free line. That's 1-800-BANTING. So that's 1-800-226-8464. Thank you for joining us today. We hope you've enjoyed learning with the CDA, and we look forward to your participation in the future.